Dr. Getson's one of the few people who knew enough to write something. We entitled the column in one of our older newsletters called Off the Grid. And he talked about complications associated with CRPS, especially the gastrointestinal. And it was really eye-opening for the RSD CRPS community. And today we're going to really be talking about some of the more difficult problems associated with CRPS. I always talk about CRPS as pure vanilla and then many flavors. And we're going to talk about the flavors today. Thank you.
All right, so we'll start with Rocky Road because that seems to be an appropriate flavor. My suspicion is that this is not going to work. This video is not going to work either. No, okay. I had this really good idea, but it's not working, so we'll just move on. I have talked to some people outside today, and they've asked me some questions about fibromyalgia and about gastrointestinal, and I put them off for this. So I explained to somebody earlier that the first lecture that I gave this morning is a lecture that I have to do so that everybody understands. It's like you have to build a foundation before you put up the house. So I do that lecture because I have to do that lecture so that everybody's on the same page as me. This one, I like to do. This to me is the enjoyable lecture because this is the one where people look at me wide-eyed because they've never heard it before. And what they've never heard before is the fact that the disease is not, as Jim said, vanilla. It is not straightforward. You do not walk in and every patient has a swollen blue arm with long nails and a hair running down the floor. I mean, it just doesn't exist that way. And I spend so much of my life arguing with colleagues, arguing with insurance companies, arguing with attorneys, arguing with everybody that it's so much more than that foundation that we talked about this morning. So I am certain that you are going to see and hear in the next 45 minutes things that you've not seen and heard before, and that you're going to go, oh my God, I didn't know that. And that's the purpose of this next 45 minutes. So there are differential diagnoses. Now please understand, in my world, the differential diagnosis is not so much what's wrong with somebody as what isn't, or what is concurrent. There is no rule in medicine that I know, and I've been doing this 39 years, there is no rule in medicine that I know that says if you have diabetes, you can't have hypertension too. And the medical community would seem to think, well, you know what, if you have CRPS, how can you be a diabetic? It must be a diabetic neuropathy. Why? Why can't you have more than one problem? So this is some of the differential diagnoses that exist. And some of them really are not totally separate. I talked earlier about brachial plexus injuries. You can have a brachial plexus injury without having CRPS. And one of the problems for me is that specialty physicians, and I have no problem with specialty physicians, they have a role, but they spend their lives looking at things through blinders. Example, and I told somebody outside, I had a patient who came into my office who was about 30 years old. She had a 2-year-old daughter. She's walking the baby to the emergency room of the hospital on a cold, wet, snowy day. And she slips on the ice, and the baby is in her arms. Now, all of you who have children, what's the first thing you do? You protect the baby. So she rotates her body away, and she puts her arm out to break the fall. And she impacts on the whole left side of her body. And 2 weeks later, she has a dystonic hand and elbow and a fractured wrist. So the orthopedic surgeon sets her wrist and says at the end of 6 weeks, you're fine. She now has no cast, and she has a contracted dystonic cold hand because while she broke her wrist, she pushed her plexus up in the process of the fall, which was way worse than any damage she did to her wrist, which heals in 6 weeks in a cast. And my big problem with my colleagues is that you can't look at patients this way. You've got to look at patients on the whole. Just as I said to you earlier today, when you look at patients, you have to look at all the facets of getting better. You also have to look at all the facets that make people sick or unwell. So let me read to you a disease which is profound and chronic and widespread and migratory and stabbing and shooting and burning that gets worse with cold weather and keeps you from sleeping and gets you tired and mentally fatigued and physical inactivity and anxiety and stress and all those things that each and every one of you have. And you also have irritable bowel and bladder and headaches and migraines and restless legs and Raynaud's syndrome, which is a discoloration, and dry eyes and dry mouth and all that stuff. Right, we all have this, right? How many people have any one of these symptoms in this room? How many people know that this came from the National Fibromyalgia website? That is the National Fibromyalgia Association's definition of fibromyalgia. Sure sounds like CRPS to me. Leading me to the conclusion that when I lecture to doctors really gets me in trouble, that fibromyalgia is in fact CRPS. So when I'm talking to doctors, I make a lot of friends 4 slides into the presentation because they're all jumping up and down and yelling, it can't be, but not my idea. That came from their website. And everybody in this room with a red tag just put their hand up. You all have fibro? So the person who asked me earlier, is it possible that you have fibro and CRPS? The answer is, yeah, you got them both because they're the same thing. Now, there are nuances and differences. I'm not telling you that it's an exact thing. But when you look at the website, okay, that's what you guys all have. I didn't make it up. And I got 2 papers, okay, that support what I say. I didn't write either one of them, obviously. Okay. So if you believe, as I do, that fibromyalgia is a subsect of reflex sympathetic dystrophy complex regional pain syndrome, those numbers that I showed you this morning of 200,000 to a couple of million multiply tenfold. I really believe there are probably 15 or 20 million people in this country with this disease in some form. Which always brings up the question, okay, why don't we know about this? So I'll answer it real quick for you. We don't have Michael J. Fox. We don't have Jerry Lewis. We don't have the late Christopher Reeve. Okay? We don't have anybody who stands up in front of a camera and says, hey, Dr. Oz, I got this CRPS stuff. And until we do, and believe me, I spend every day of my life working on this, until we find somebody, okay, and I'll give you a piece of hot off the press information. It is my belief on really good source that Morgan Freeman actually has CRPS in his hand. If you've ever seen him on a talk show, he frequently will wear a glove on his hand, and his hand is a little bit dystonic. And if I can get to Morgan Freeman, okay, so, okay, I'm working on it, okay? I'm sorry? Yeah, well, here's the problem with Paula Abdul, since you bring it up, okay? Paula Abdul, twofold. Number one, Paula Abdul was on the Dr. Oz show. She sat there and talked about her RSD, and she said what cured her RSD was packing her shoulder in ice. Now, by show of hands, how many people in this room that have CRPS get better when they pack it in ice? Okay, well, that's 2 out of a room full. And she spent 10 minutes talking about the disease and 30 minutes talking about her line of cosmetics. Didn't do us a whole heck of a lot of good. So what I'm really looking for is somebody that will come out and say, yes, I have this disease, but I managed to live a life through it, and here's what it's about. And when that day comes, and it will come. I'm sorry? Hulk Hogan? I'll shoot for Morgan Freeman, forgive me, but you know. Now, a rumor crossed my path a couple of weeks ago that another star has this, and I haven't been able to verify it, but I'm trying, and that is George Clooney, who would have been really nice at this conference because instead of having 150, I would have had 1,500 women. But if we get someone that we know for a fact is willing to help us by expressing that he or she has the disease and who really is sort of a reliable spokesperson, I think it will change the whole situation. So let's talk about some other things. Let's talk about MS. I have 9 patients in my practice, all female, who have both diagnoses, MS and CRPS. All 9 have been treated for MS. All 9, the MS got better, and 7 of the 9, the CRPS got better, leading to the undeniable thought that even though it's just a small number of people, okay, there is a link between the two. So let's talk about CRPS symptoms: burning, pain, skin sensitivity to touch. Geez, the easy way, all the symptoms of fibro, right? Abnormal skin color changes, temperature changes, edema, sweating, swelling, weakness, tremor, dystonia, neglect, not using, that's what neglect means, not that the individual is being neglected, but that the affected part is not, abnormal hair growth and or nail growth. And please remember, it means accelerated or diminished. It can be either or, okay? So some vasomotor changes, which are hair growth, more on one side than the other, not to mention the color change, a sweaty palm, a dystonic hand, neurogenic edema, different from cardiac edema. Cardiac swelling responds to Lasix and other diuretics. Neurogenic edema, as a general rule, does not. So people will come in and say, my leg is this fat, give me a water pill, and you give them a water pill, it doesn't work. And then they wonder why it doesn't work, because it's not going to work. There's a lady that when she gets into a flare, the knee swells and it turns red. I had to put one like that in. Okay, someone who has both the swelling and the discoloration. This is easy. When somebody walks in like this, of course, I will tell you that somebody walks in most doctors' offices with this leg, and they tell them they have Raynaud's syndrome, which is a squeezing off of the blood vessels to cause less circulation, and it usually is temperature related, which is a little difficult to have Raynaud's when it's 85 degrees out and the office is 70-some degrees, but that's what you hear. Oh, they got Raynaud's phenomenon. Okay? So let's talk about organs that are involved. Anybody in the room ever hear that it can't affect your internal organs? Okay, that's a lie. For those of you who do not know how to read an electrocardiogram, these are the heartbeats. Okay, it's about 40 beats a minute. The normal heart beats anywhere from 60 to 80 times a minute. 40 is about half of what a female should beat. This lady has a pacemaker. She has no heart disease. But the sympathetic response to the heart, telling it how fast to beat, isn't correct. It's misguided, like so much in this disease. And because it's misguided, right, her heart is beating to a point where she's in danger for passing out or falling down. So interestingly enough, this is a 45-year-old female who went to the emergency room after she, in fact, blacked out. She was a diabetic, but that blood sugar is not a problem. She had a history of thyroid dysfunction, but her thyroid function studies were normal, and she had no other medical history. Hence, she wound up with a pacemaker, and she doesn't pass out anymore. Because, as you probably know, a pacemaker only kicks in when the heart rate goes down too low for the heart to beat in its normal rhythm. Bradyarrhythmia is the slowing of the heart, usually occurs in women under 40. Tachycardia, accelerated rate, usually women in their 20s. They come in with heart rates of 110, 115, 120 routinely. Atypical rhythms means extra beats or irregular rhythms. Chest pain. Okay, and chest pain that is not cardiac in nature. Okay, there's a very technical term, the sensitization of that nerve following a brachial plexus injury. So here's a story about a patient of mine who at the age of 50 had a massive heart attack. And I walked in to see him and I said to him, I have some good news and I have some bad news. Because we already knew he had the heart attack. And he said, what's that? I said, well, the good news is we're going to take you to the operating room tomorrow. They're going to cut open your chest. We're going to give you 4 bypasses and you're going to live a long time. He said, well, that's good news. What's the bad news? I said, you're going to live with chest pain for the rest of your life. Because back in those days, we did not understand how to buffer people with ketamine infusions. 12 years later, he has very little heart problem, and he has chest pain that is unrelenting and that we can't get rid of. And it's just down the center of his chest. Because when they cut him open, which we had to do to save his life, we kind of doomed him to a life in pain. Today, maybe it would be different because we'd give him intraoperative ketamine. All right? Visual disturbances. Double vision, blurred vision, ocular migraines. For those of you who don't know what ocular migraines are, you don't get a headache with ocular migraines. You get floaters and things that... I had one once, and I was sitting in a room, and fireworks started to go off. Wild. I mean, I'm sitting there, it's like fireworks, and the first thing is, oh my God, I'm having a stroke. And the second thing is, no, it's just an ocular migraine, so I just sat back, closed my eyes, and watched the show. Okay? They were in black and white and not in color, but that's an ocular migraine. Vision loss, people are getting field cuts where they lose the vision. Photophobia, which is the sensitivity of the eyes to light. I have people come into the office with two pair of sunglasses inside, one in front of the other because the overhead lights bother them, okay? And the newest one, which will be very familiar to at least one person or two in this audience, okay, which is burning of the eyes, which we think is coming from a nerve in the back of the neck, okay? And there's nothing that we have found at this point that takes that burning away. Although the ketamine diminishes it for a short period of time, it just keeps coming back in. I've sent people to neuro-ophthalmologists, people who have a specialty within a specialty, and nobody seems to know. Drops don't work, treatments don't work, and it's something that we're seeing more and more of, and I have less and less information at this point as to what to do. Okay? Migraines, most people that come in with migraines know the difference between a migraine and an RSD-related headache. Okay? Most of them are greater occipital nerve headaches. That's where the occipital nerves are, and right at the base of the head, right beneath that bone, beneath the hairline on a male. And if you block the occipital nerves, the headaches just go away. I mean, before the person gets up and leaves the room, as a general rule, the headaches are gone. I have found that if you block the occipital nerves, I block them with homeopathic agents. I don't use Novocaine and cortisone because they actually work better, the homeopathics. And people get 6 months relief from those headaches. But they are not migraines, they're occipital nerve headaches. That big fancy word, otorhinolaryngology, is ear, nose, and throat, okay? Otophobia is sensitivity to loud noise. I get a husband and wife comes in, the wife's the patient, I said, any problem with the television? He's going, yeah, my God, I'm like sitting with earmuffs on because she's got it cranked up so loud because she can't hear. And the next one is exactly the opposite. The sound is so quiet that you can't hear because it's hypersensitive. It's that same as hair and nail growth. It can go either way. It's the sensitivity to the sound. There's a sensitivity to vibration. I have people that ride in a car, and someone will come up next to them, a kid will come up, got their boombox, the bass booming, okay? And they actually get pain sitting in the car from the car next to them because the bass is cranked up so loud, okay? And this one, which is my favorite one of this list, hoarseness. Okay, people who get up and get hoarse and think they're getting sick, and an hour later the hoarseness goes away, and they never get sick. It is a function of the CRPS, an irritation of the branchial, not brachial, branchial plexus that causes this, and it comes and goes, and it's never associated with being sick. Interestingly enough, by the way, what you can do for that is exactly what I told you not to do earlier when I talked about hydrochloric acid. The H2 blockers, the Zantacs of the world, actually help that hoarseness sometimes. Okay? I have one patient who's not here today who began to stutter when the CRPS got worse. I mean, you couldn't understand them. Okay? He had 1 week of IV ketamine. He talks perfectly normally. 1. Dental disease, why so many? Why do I have so many people in their 20s, okay, who have full dentures, who've had all their teeth extracted? Their teeth are in such poor repair, okay? And part of it is from compromise of the immune system, and part of that is from disruption of the dental nerve roots. But the greatest reason is that the medicines cause a change in lifestyle, cause poor oral hygiene, cause poor nutrition, cause a loss of saliva, which I mentioned earlier, which cause decay and periodontal disease, and teeth fall out. All interconnected. Neurodermatitis, that's one of many pictures. They are little skin eruptions. Dry skin, hyperhidrosis is excessive sweating. Neurodermatitis is a little rash that comes for no reason. They start out looking almost like little whitehead pimples. Okay, they itch. People scratch them. They look like that. Okay, and then they go away. And they could come and go for no reason. Sometimes they come and never come back. Sometimes they come every couple of months. Okay, there's not much you can do other than put a little topical steroid on them to keep the itch down, to keep the scratching down, to keep the scarring down. DERCUM'S disease is a rare condition, painful lipomas. Now, I don't know if in the back you can see that, but there's just a fatty tumor on the back of this guy's neck. Okay? They're just fat deposits, which are very, very common in the world. People get these fatty tumors all the time. In DERCUM'S disease, they actually hurt. And the only way that you can get rid of the pain is to treat the underlying CRPS cause. There's a DERCUM'S disease foundation, if you know anybody that has it, that you can find online. Okay? This is what we call LIVIDO reticularis. There it is at the arm. Okay? It's about as pronounced a case as you will see. This young lady has this 24/7, 365. It just gets more vivid when she's in a flare. And then it fades out when she starts to, it never goes away. And this is her abdomen. She also has it to a lesser degree on her back. So now the gastrointestinal stuff, which Jim mentioned earlier.
Before you leave, I want to go on to this.
I'm sorry?
A lot of people call our office all the time with ulcers, open sores. I mean, do you find that the ibuprofen helps?
Okay, so there's a process there. What happens is that when you get back to the individual that I showed you earlier with the neurogenic edema, where the legs are so swollen, the skin breaks down because the pressure on the skin is so great, okay, that it causes it to break down. When the skin breaks down, it tends to become infected. When it becomes infected, the immune system is compromised to the point that the body can't fight the infection. So this domino effect now gives you infected leg ulcers, which came ultimately from the CRPS to getting out of control, causing the, et cetera, and it's a very, very difficult situation to treat simply because you can't boost the immune system the way you want. So you wind up having to treat the wound ulcers topically, and a lot of these individuals wind up in the care of wound specialists with wrappings and all. But the trick to the whole thing is to get rid of the neurogenic edema, which the ketamine helps do as a general rule. So, peptic ulcer disease, acid peptic disease, irritable bowel, nausea, vomiting. Normally, endoscopy, gastroscopy doesn't find much. Sometimes there'll be an ulcer, sometimes there's a pre-ulcer. But here's the key word, gastroparesis. And I know there's at least one person who's sitting there going, yep, okay. And she will see more of her in a moment. But the bottom line here is gastroparesis really is first and foremost found in diabetics. And very simply what that means is that when you eat, there is a process by which the food is broken down. There's a valve that opens up going into the stomach. The food is decomposed by the acid in the stomach. There's a valve on the other end that opens up and lets the food go out. In this disease, that second valve doesn't work right. And because it doesn't work right, food accumulates in the stomach. And because food accumulates in the stomach, the next time you eat, there's no place for it to go. So it comes back up. And you have people that eat and vomit, eat and vomit, eat and vomit. Their stomach bloats, they get stomach pain, they get distress. So I've only had 2 failures of Botox, okay, who wound up in operating rooms and wound up having fundal plications with GI surgeons. And what makes this interesting for me, other than the fact that we made them better, is that they're sisters. Another interesting finding has to do with pancreatitis. People who have stomach pains, horrible stomach pains, the doctor does a battery of laboratory tests, the pancreatic enzymes are elevated, and these are people that have no reason to have pancreatitis. Number 1 reason for pancreatitis is diabetes. Number 2 reason is trauma. Number 3 reason is excessive alcohol intake. Okay? And in individuals who have none of these, the pancreatic enzymes get elevated because they, in essence, have CRPS-induced pancreatitis. The other symptoms, dysphagia, is difficulty swallowing, and biliary dyskinesia means that the bile ducts are not working properly, so you get gallbladder-type attacks. Urinary symptoms, it's another reason I make friends when I deal with the doctors. I have women who come in who are diagnosed with interstitial cystitis. Urinary incontinence, dysuria, difficulty urinating, irritability or difficulty voiding. And the doctors, the specialists, treat the interstitial cystitis, but it just doesn't seem to get better. And we have taken these individuals, injected Botox into the pelvic floor. That helps. Sometimes we put people into the hospital and put a lumbar epidural catheter into them, which helps to reverse the symptoms of the CRPS, and they walk out with bladders that work much better. A lot of these women wound up with bladder pacemakers. I'm not sure that the bladder pacemakers they do help some, okay? But I always felt before you implant a permanent device, whatever it is, you should try to not implant a permanent device and see if you can get it better the other way. Menstrual dysfunction, polymenorrhea is excessive number of menstrual periods. Dysmenorrhea is pain with menstrual periods. Menomenorrhagia is bleeding in between menstrual periods. And secondary amenorrhea means not having menstrual periods when you used to have them, as opposed to menopausal or premenopausal. I had the one pregnant lady that I saw here, I asked her whether or not she was feeling better. She gets to the third trimester of her pregnancy. I have seen more and more women come in the third trimester of pregnancy. Okay, they become asymptomatic and lasting into childbirth and beyond if they breastfeed. I have nine females that all followed the same pattern. Not a coincidence when you have 9. We had a discussion today about Morton's neuromas. Neuromas are mechanically induced degenerative neuropathies affecting the nerve where you see the picture there. It is 8 to 10 times more likely in women than men. And if any of you are sitting here with a Morton's neuroma, here's my advice to you. Do not let them operate on it. Because it is just, it's an invitation, it's a red flag in front of a bull. There are ways to cryosurgically treat this, to freeze the neuroma and make it asymptomatic, that you do not run the risk of turning it into or accelerating the CRPS. It is a very, very common cause. I had a patient who stepped on a nail in work. He had work boots on. The nail went through the boot and through his foot. He developed a Morton's neuroma. The podiatrist was going to go in and take his neuroma out. I threw my body in front of the car so that he didn't do it. We sent him to New York where they cryosurgically ablated the neuroma. He had surgery to fix the mechanical problem of his foot after that with ketamine anesthesia, and he went back to work, pain-free. One of the few people I've seen that I got early on in the process. I saw him a week after he stepped on the nail. We were very fortunate. Vertigo, dizziness. Sometimes meclizine, which is antivert, helps. Again, treat the underlying problem when you can. Syncope is blacking out, the next step beyond vertigo. Interesting story, okay? 44-year-old woman comes into my office following a car accident. She had a pre-existing brachial plexus reflex sympathetic dystrophy, okay? And we did all kinds of workups, and she kept having drop attacks. She would walk along and literally just fall on the ground. She's walking out the elevator one day, and I go out, and she's laying on the ground. So we did everything. We did brain MRIs, EEGs, laboratory testing, and we even looked at her carotid arteries because the blood flows up in the carotid artery. Everything was normal. And I put her in a cervical collar, and she got better, and here's how that happened. I made the people in the hospital do carotid ultrasounds, which they do by just one at a time. They measure the flow of the blood up the side of the neck. So what I had them do was I had them measure the blood flow on one side of the neck with the head turned to the side. And when we turned it to the one side, which was, this was the good side, the bad side, I'm sorry. Because of her plexus injury, her shoulder was up. So her neck was shorter. So when she turned it this way to the bad side, it really didn't have much effect on her carotid artery because she had diminished blood flow there anyhow, and this one was doing the job. When she went this way and blocked off the good artery, she passed out. Right there in the x-ray department. She just went down on the ground. So we put her in a cervical collar to bring down the shoulder, thereby improving the blood flow in her neck so that when she turned her head, she had adequate blood flow and not pass out. They called me from the x-ray department and went, "She's on the floor." And I went, "Good?" They said, "Why?" Because I said, "Now we know what's the matter with her." Cognitive dysfunction, the inability to remember. I remember exactly what I wore to my senior prom, but I can't remember my Social Security number. And all the heads go like this, okay? Up until this week, I believe that a lot of this had to do with the fact that, number one, we separate ourselves with this disease from other individuals, so the interaction is not like it used to be. We're not at the workforce where our brain has to work. We may be in the house by ourselves. That's number one. Number two, medications tend to dull the senses. 3, depression tends to dull the senses. This week I found that the neurotransmitters of epinephrine and norepinephrine are impacted negatively, and that's contributing to the cognitive dysfunction. Film at 11, tune in, we're still working on it. I think that's more of an individual thing as opposed to something that's very common. It's just the way you're responding to your pain sensors. There is a program called Lumosity, which is a computer-based program which is either free or very inexpensive, which I encourage patients to do because it keeps the mind active and busy. And if you're home and sitting in front of a computer, assuming that you can use a computer and a mouse, it's a good one to use. Okay. Some other things, lethargy, fatigue, weakness, sleep disturbance, shortness of breath because the plexus is impacted. Similarly, the inability to take a deep breath. We talked about neurogenic edema, muscle weakness, endocrine dysfunction. I talked earlier about adrenal. And Gardner-Diamond syndrome, which is bruising in areas that were never injured. Okay, why is my hand all black and blue? I didn't do anything, I didn't hit it. Now, chronic pain leads to depression. I have patients come into my office and I say, so how do you feel about being, I'm not depressed. Okay, here's my question, it's always the same. You get up in the morning and you feel like crap. You spend the whole day not doing what you used to do, depending on other people. You go to bed at night feeling like crap, knowing you're going to get up the following morning feeling like crap. You have two choices. You're either depressed or you're crazy, because you should be depressed. Okay? Now, please don't misunderstand. Having the disease of depression is different from being depressed. Somebody dies, you get depressed. You lose your job, you get depressed. It's normal. So it's okay to be depressed, but you need to deal with it. Speaking of which, I'll step aside for a second. One of the individuals here told me that there is I was talking about Cymbalta earlier this morning, and she told me that there is a website where the FDA has posted about how difficult it is to come off of Cymbalta, and a nationwide lawsuit about individuals suing the Lilly manufacturing company for the inability to get off of Cymbalta. So anybody who's on Cymbalta wants to know about it. If you want to raise your hand, she's got the information. Anyhow, getting back to what I'm saying, depression comes from chronic pain. Depression begets anxiety. Why do we get anxious? Because you're depressed all the time. You get anxious about being depressed. Please don't let any pharmaceutical company tell you that there's a drug that treats anxiety and depression, because it doesn't exist. You have to know which one came first and treat that one, and you can make the second one go away. SSRIs, Paxil, Prozac, Zoloft don't work. SNRIs work a little bit. Okay? To me, it's about going in and balancing the neurotransmitters. Okay? Genetics was a question that was asked, so I'm going to give you a story other than the one I told you before. A 37-year-old casino worker was struck by a money cart in the left lateral thigh, the left side of her thigh, and subsequently developed CRPS in the limb that levers the left arm. A year later, her sister, a 35-year-old police officer, broadsided in her patrol car. The handle goes into the left lateral thigh, and she develops CRPS in exactly the same place that migrates to the left arm in exactly the same way. Do I believe that this is genetic? Absolutely. 18 families in my practice have more than one individual with CRPS, and growing. And we are working on a genetic study as we speak to see if I can identify a gene. There's only one article in the literature with 31 families, but we are looking to find a gene. But there's no question that there is a genetic predisposition to this. We just don't know what it is. Okay, some real quick pictures about thermography. I talked to you about that before. Thermography works because it deals with sympathetic and chronic injuries. So I tell this story of a 40-year-old woman who's sitting on the third row of a football stadium, which, by the way, was Lincoln Financial Field, at a charity event, when one of the players, who happened to be the former punter, Sal Rocca, for those of you who are Eagles fans, kicked the ball into the crowd, and it went way up into the crowd. And the idea was, get the ball and throw it back so that we can go around the stadium and throw and kick the ball up into the stands. And some guy up there who thought he was Tom Brady and was going to throw the ball back decided he was going to heave the ball back from way up in the stands, and it didn't quite make it. It made it to her face. Now, when you're sitting on the third row and this football is coming at your face, you do this, because you don't want it to hit in your face. All right? So not only do you have the velocity of the football, but you have the force of gravity. So it hit her in the hand, okay, smacked back into her face, bruising her face, hyperextended her wrist, breaking her wrist, okay, and sending her to the emergency room where she was ultimately treated and casted. Because not only did the ball hit her, but the tip of the ball hit her. Even worse. So she came in to see me, and the thermograph, it's the left arm, the thermographic pictures show temperature gradients, which, by the way, should never be more than 1 degree, of between 2.0 and 3.0 degrees between the left side and the right side of her arm. Now, when you see this thermographically, there is no question that this is CRPS, because it can't be anything else. If it was circulatory, the person would come in with a purple arm. And they're the only two things that would give you this kind of cold limb. And this is her hand, and it goes up into her arm. You see the difference. If you've never seen a thermogram before, here's the color scale. That's cold, that's hot. The thumb is gone because it's so far down that you can't even see it. Okay. Sides of her arms, okay? So it's always been my opinion that thermography can actually find the sympathetic dysfunction in a patient before the symptoms arise. What do I mean? A 43-year-old woman's on an airline wearing sandals. Okay, she cuts her foot, and that's the key word in this, on a piece of wire. 2.5 years later, she had foot and ankle pain. That's it. So we took pictures of her foot. And sure enough, that left foot and ankle has, up into the leg, a pattern that is consistent with CRPS. And that should have been enough, because there it is, this is the inside of the left foot and ankle, this is the outside of the left foot and ankle. That should have been enough, but it really wasn't enough for me, okay? Because the left side of her arm and the left fingers are much colder than the right. She didn't have any pain, she didn't have any symptoms till about a year after I first saw her. And I see this time and time again. The camera is so sensitive, it will pick up sympathetic dysfunction months to years before the patient becomes symptomatic. And for any of you who have had this disease that has started one place and moved to another, invariably the second place is worse than the first. Good news, bad news. Good news is that when they come in complaining about this, I can say, hey, now that I know what it is, I can get on it right away. Bad news is that if the insurance company wasn't the way the insurance company was, I would block them before they ever had symptoms, because you might prevent them from getting symptoms. I live, sometimes, in a perfect world. We all hallucinate. That's my hallucination. I live in one without lawyers and insurance companies and pharmaceutical companies some days, and I'm able to say, geez, I could really do well for people if you just put me in that place. But knowledge is power. And the knowledge that this is going to be a problem allows me to help people early on. I told you folks earlier, I rarely see anybody in the first couple of weeks or months after CRPS. By the time I see them, they've seen 4 or 5, 6 doctors, had $1 million worth of testing, and they're 2 years into this. And I look at the records and say, why weren't you here a year and a half ago? And we're back to, I've sort of circled back to identifying somebody who can help us get the word out. That notwithstanding, when I get somebody like this, even though the CRPS may be 2.5 years, this one's new. And so there really is some more we can do, because the first time they walk in and say, you know what, my hand's feeling, bang, okay, let's block them. Let's do something now. And invariably, we're helping at least that part of the problem. So I have one question for all of you before I give you this last slide. From my knowledge, have you seen and heard things today in this part of this lecture that are applicable to you or people that you know? And has it been for you stuff that you haven't really heard before? Okay. Then go out and talk to people and tell them what you heard and tell them what you learned, because there's an old Pantene hair commercial that said, I told two friends who told two friends who told two friends. Okay? And really, for now, it's the best we have. I'll worry about educating the doctors. You worry about educating the non-doctors, because believe me when I tell you, you're not going to educate the doctors. They're not going to listen. Okay? What I try and tell doctors when I lecture them is this: you don't ever have to treat this disease. You just have to recognize it and get it to somebody who can. I don't understand dermatology, but I know there's a dermatologist right above me. In medical school, I had a professor who gave me a wise piece of information. Okay? He said, you only have two jobs when you embark on a career being a doctor: make people better or get them to somebody who can make them better. And he was right. So I leave you with this, because Jim Broach would be upset if I didn't have at least one Sherlock Holmes reference. Okay? Each fact is suggestive in itself. Together, they have a cumulative force. It is about the entirety of treating someone. It is not about the thumb or the wrist or the hand or the eye. It's about understanding that this disease is complex. That word is right. I don't know about regional, but complex is right. It is a complex disorder, and it's difficult. Okay? It starts with you guys. It gets to me and other people like me, but you guys have to be a part of it, which is why in my 3 lectures today, I tried to talk to you about the entirety of treating the patient. We're going to have another lecture after this. We're going to have a question and answer session after that.